You know, it's quite astonishing when you stop and think about it. We breathe something like, what, 20,000 times a day? And mostly we don't give it a single conscious thought. It just happens.
Right. This incredibly vital, continuous process just hums along in the background.
Until it doesn't, right? Like that gasp after you suddenly sprint for a bus, or that really unsettling feeling of dyspnea, that awareness of being short of breath, even if technically your blood gases are fine.
Exactly. It's usually only in those moments we realize how complex and, well, how resilient this whole breathing thing actually is.
Yeah, and most of us are completely unaware of the intricate symphony playing out inside us to keep us alive breath by breath.
It really highlights how exquisitely regulated our physiology is and how quickly we notice when even one small part of that system falters.
And that's precisely what we're diving into today. We're taking a focused look at the control of ventilation, pulling directly from Boron and Boulpaep's Medical Physiology.
A foundational text.
Absolutely. And our mission here is to kind of demystify how your body automatically manages breathing, how it adapts sometimes dramatically to your needs, and critically, what happens when that control goes wrong.
You're going to discover why maybe a chest infection can make you feel breathless even with normal oxygen levels. Or the classic one, why giving too much oxygen to certain patients can actually, paradoxically, stop them breathing.
These aren't just abstract facts, are they? They're really keys to unlocking deeper medical understanding.
Definitely not just academic. Understanding this is, well, it's fundamental. It underpins so much in diagnostics, pathology, treatment. It's where you get those aha moments, seeing how the physiology connects to the clinic.
Okay, so let's jump in. How does the brain even set this basic rhythm? I mean, how does it keep us breathing day in, day out, even when we're totally out cold, asleep? What's the secret?
Well, the fascinating thing is that breathing is primarily automatic, right?
Huh.
Subconscious. It's driven by our central nervous system. Deep inside the brainstem, specifically the medulla, with some important input from the pons too, there's this network of neurons.
Okay.
And this network acts like what we call a central pattern generator, or CPG. Think of it as the brain's internal metronome for breathing.
A metronome, I like that.
Yeah. Now, the exact spot for the CPG responsible for apnea, that's just normal, quiet breathing, it's still actually a bit debated, believe it or not, but we know it's definitely within the medulla.
Which still begs the question, how does something so vital just run itself without us thinking about it?
Right. It does that through specialized neurons called respiratory-related neurons, or RRNs. These guys are found in the CPG and other nearby brainstem areas.
And they fire in time with breathing.
Precisely. Their activity patterns directly correlate with the breathing cycle. Some fire during inspiration, others during expiration. You can imagine them like sections in an orchestra, maybe, each playing its part, inhale or exhale at just the right time.
And these are orchestrated by...
By premotor neurons, which then talk directly to the motor neurons, the one that actually control your respiratory muscles.
Got it. So the orchestra analogy holds up. And for normal, quiet breathing, apnea, you mentioned the muscles, it's mostly the diaphragm doing the heavy lifting.
That's right. The diaphragm is the absolute star for inspiration. It gets its instructions from the phrenic nerve, which, interestingly, originates way up in the neck from the C3 to C5 spinal cord segments.
C3, 4, 5 keeps the diaphragm alive, right?
That's the classic mnemonic. So during apnea, our regular, quiet breathing at rest, it's really just the diaphragm and maybe a few external intercostal muscles doing the work during inspiration.
And expiration is just letting go.
Exactly. It's passive, the inspiratory muscles relax, and the natural elastic recoil of your chest wall and lungs just pushes the air out, like letting the air out of a stretched balloon. Simple as that.
But okay, what about when we need more air, like hitting the gym hard or running upstairs? That feels very active, not passive at all.
No, definitely not passive then. When you need more air, the activity in that phrenic nerve ramps up. The diaphragm contracts harder and faster.
Okay.
Plus, your brain calls in the reserves, the accessory muscles. For inspiration, you've got muscles like the sternocleidomastoids in your neck helping pull the chest up. And for expiration, you actively use muscles like your abdominals to push the air out forcefully.
So you get faster, deeper breaths.
Exactly. You dramatically increase both the frequency and the volume of your breathing.
And circling back to dyspnea, that feeling of breathlessness, you said it highlights how critical the automatic rhythm is.
Precisely. Dyspnea, that often frightening feeling, can happen even if your oxygen and CO2 levels are perfectly normal on paper.
How so?
Well, think about increased airway resistance, maybe from asthma or bronchitis. Your body has to work much, much harder to move air against that resistance. Even if the gas exchange itself is okay for the moment, It's the sensation of that increased effort that triggers the feeling of dyspnea. It's your body telling you something's wrong with the mechanics.
Right, the effort involved. Okay, so the CPG sets the beat, like the metronome. But something has to tell it when to speed up or slow down based on what our body actually needs right now. This is where it gets really interesting, I think. How does our body know? It's like having internal air quality monitors running constantly.
That's a great way to put it. While the CPG is the clock, we have chemoreceptors acting as these incredibly vigilant internal sensors. They're constantly monitoring our arterial blood,
Specifically looking at.
specifically oxygen levels, PO2, carbon dioxide levels, PCO2, and pH, how acidic the blood is. And based on what they find, they send signals back to adjust breathing.
And there are two main types, you said, peripheral and central.
That's right. Let's start with the peripheral ones. They're located outside the brain itself.
Okay, where are they and
Yeah.
what gets their attention?
The main peripheral chemoreceptors are the carotid bodies, found right in your neck where the main carotid artery splits, and the aortic bodies, which are kind of scattered along the underside of the arch of your aorta in the chest.
Strategic locations.
Very strategic. Their primary job, their main sensitivity, is to detect significant drops in arterial PO2 low oxygen, or hypoxia.
Our hypoxia alarm system.
Exactly. But importantly, they're also stimulated by high PCO2 and low pH. And what's really neat is that high CO2 or low pH actually makes them more sensitive to low oxygen. It's like they shout louder when multiple things are wrong.
A combined response. Makes sense. And how do they send the message?
You relay the info up to the medulla, the brainstem control center, via cranial nerves. The glossopharyngeal nerve, that's CNIX, handles the signals from the carotid bodies. And the vagus nerve, CNX, takes care of the aortic bodies.
Okay, so they're the rapid response team for low oxygen. What's the actual cell inside them that's doing the sensing? Must be pretty special.
It really is. The key players are the glomus cells, or type I cells. Think of them as these remarkable multi-thread detectors. They're exquisitely sensitive to all three: low O2, high CO2, and low pH.
Wow, all three.
Yes. And the mechanism is fascinating, though we'll keep it relatively simple. Basically, any of those stimuli, low O2, high CO2, low pH, trigger a common pathway. They inhibit certain potassium channels in the glomus cell membrane.
Okay, blocking potassium exit.
Right, which makes the inside of the cell more positive. It depolarizes. This depolarization opens up voltage-gated calcium channels. Calcium rushes into the cell.
And calcium influx usually means...
Neurotransmitter release.
Well.
Exactly. The glomus cell releases neurotransmitters, which then stimulate the afferent nerve endings, those glossopharyngeal or vagus nerve fibers we mentioned, sending that urgent signal straight to the medulla. It's a rapid-fire alert system.
Incredible efficiency. A real-time emergency broadcast.
Okay, so those are the peripheral guys, our frontline defense against acute changes, especially hypoxia. What about the central chemoreceptors? Where are they and what's their main focus? The central chemoreceptors are, as the name suggests, located centrally within the medulla itself. Key areas include the ventrolateral medulla, or VLM, and the medullary, the lobes. They're literally embedded in the brain tissue behind the blood-brain barrier.
Inside the fortress, so to speak. And their sensitivity.
Their primary sensitivity is to increases in arterial PCO2. But here's the critical twist, and it's a really important one.
Okay.
They don't actually sense the PCO2 molecule directly. What happens is CO2 from the arterial blood very easily crosses the blood-brain barrier into the brain's extracellular fluid and the cerebrospinal fluid, the CSF.
Right, CO2 is lipid-soluble, crosses easily.
Exactly. Once it's in the brain, ETF-CSF, CO2 combines with water to form carbonic acid, which then dissociates into hydrogen ions, H+, and bicarbonate ions, HCO3. So an increase in arterial PCO2 leads to a fall in the local pH within the brain tissue itself.
Ah, so it's the resulting acidity, the drop in pH in the brain fluid that they're actually detecting.
Precisely. It's the H+ concentration, the pH decrease. That is the actual sense parameter by the central chemoreceptors, not the PCO2 directly.
That's a crucial detail, and the blood-brain barrier's role here is key then.
Absolutely key. Because while CO2 zips across the BBD, hydrogen ions and bicarbonate ions don't cross nearly as easily.
Meaning
That if you have a metabolic acid-based problem in your blood, say lactic acidosis from intense exercise or ketoacidosis from diabetes, the change in blood pH has a much slower and smaller effect on the brain's pH compared to a change in PCO2. Respiratory changes have a much faster impact on central chemoreceptor drive. CO2 gets that VIP pass.
Got it. And are there specific neurons identified as these central sensors?
Yes, research points strongly towards certain serotonergic neurons, neurons that use serotonin as their neurotransmitter, particularly those in the medullary raphe and the VLM.
Mm.
They seem uniquely sensitive to pH changes.
And their location is important.
It seems so. They're often found close to arterioles within the medulla, perfectly positioned to sense changes in PCO2 diffusing out of the blood and the resulting pH shifts.
And you mentioned a link to SIDs earlier.
Yes, tragically, a significant number of infants who have died from SI sudden infant death syndrome have been found to have a deficiency in these brainstem serotonergic neurons. This fits with the theory that at least some SIDs cases involve a defect in this central respiratory chemoreception, making them less responsive to rise in CO2, especially during sleep.
That really underscores the clinical importance, and it brings us to another major clinical point. You mentioned CO2 narcosis. Can you unpack that a bit more in light of these central chemoreceptors?
Right, CO2 narcosis is a classic and dangerous situation, often seen in patients with chronic lung disease, like severe emphysema or COPD, who retain CO2 chronically. Their arterial PCO2 is persistently high.
So their central chemoreceptors must be getting hammered with that low pH signal constantly.
Initially, yes, but over time, the body compensates. The brain actively transports bicarbonate into the CSF, buffering the excess H+ ions. So the CSF pH actually returns towards normal, despite the high arterial PCO2.
Ah, so the central chemoreceptors adapt. They become less sensitive to the high CO2 because their local pH environment has been partially corrected?
Exactly, they become blunted. This means these patients lose their primary drive to breathe from CO2 via the central chemoreceptors. So what becomes their main stimulus to breathe?
It must be the peripheral chemoreceptors sensing low oxygen, the hypoxic drive.
Precisely. They become much more reliant on that hypoxic drive mediated by the carotid and aortic bodies.
Okay, now I see the danger. If you give such a patient too much supplemental oxygen.
You remove their remaining drive to breathe. If you raise their arterial PO too much, the peripheral chemoreceptors quiet down. Since the central ones are already blunted to CO2, their overall ventilation can decrease dramatically.
Leading to even higher PCO2 levels.
Dangerously high. PCO2 can climb, sometimes over 100 millimeters of mercury. And at those extreme levels, CO2 itself acts like an anesthetic, a narcotic, directly depressing the central nervous system, including the respiratory centers. This worsens the hypoventilation. It's a vicious cycle that can be fatal. It's the classic too much of a good thing scenario in medicine.
Wow. A perfect illustration of how these systems interact and how interventions need to be carefully considered based on the underlying physiology. So it's clear the peripheral and central systems don't work in isolation. They're integrated.
Absolutely integrated.
Yeah.
Hypoxia makes you more sensitive to CO2, and high CO2 makes you more sensitive to hypoxia. They work synergistically to maintain homeostasis, to keep those blood gases stable.
Incredible. Okay, so we've got the brain's automatic rhythm generator, the CPG. We've got the vigilant chemoreceptors acting as internal gas sensors. But breathing isn't just about O2 and CO2, is it? It feels like it's tied into so much more. Like you said, it's a dance between reflexes and conscious will.
That's a perfect way to think about it. Beyond those core chemical controls, breathing is constantly being fine-tuned and modulated by sensory feedback, especially from the lungs themselves, and also by powerful commands coming down from higher brain centers. This lets us do everything from talking to swimming to reacting emotional.
Let's touch on that feedback from the lungs first. What kind of sensors or receptors are we talking about down there in the airways and lung tissue?
There are several important types. First, we have the slowly adapting pulmonary stretch receptors, or PSRs. These are mechanoreceptors, meaning they sense physical stretch. They're located in the smooth muscle layer of the airways.
And they sense lung volume.
Essentially, yes.
Hmm.
They detect how much the airway walls are being stretched during inflation. They're key players in something called the Herring-Breuer inflation reflex.
Herring-Breuer, that sounds familiar. It stops you from overinflating your lungs.
That's the main idea. Lung inflation activates these PSRs, which send signals via the vagus nerve back to the brainstem to inhibit further inspiration. It's basically saying, okay, lungs are full enough, stop inhaling now. While this reflex is thought to be more critical in infants, helping set their tidal volume. In adults during normal breathing, it's less dominant, but it likely helps optimize breathing patterns to minimize the work of breathing, especially during exercise.
Okay, so volume sensors. What about detecting, say, smoke or dust irritants?
For that, we have the rapidly adapting PSRs, often just called irritant receptors. As the name suggests, they adapt quickly to a constant stimulus, but they respond vigorously to things like inhaled dust, smoke, noxious gases like ammonia, or even cold air. They also respond to histamine release during an allergic reaction or asthma attack.
And what do they trigger?
They trigger protective reflexes, coughing, sneezing, maybe bronchoconstriction to limit deeper penetration of the irritant. They're really important for sensing nasty stuff in the airways or pathological processes like inflammation.
Makes sense. And there's a third type, C fiber receptors.
Yes, the C fiber receptors, sometimes called J receptors, for juxtapulmonary capillary receptors because many are near the alveolar capillaries. These are endings of unmyelinated C fibers found both in the lung parenchyma near the alveoli and in the conducting airways.
Ah, they sense.
They respond to both chemical stimuli like capsaicin, the stuff in chili peppers, or inflammatory mediators, and mechanical stimuli like pulmonary edema, fluid in the lungs, which increases interstitial pressure.
And their response.
When activated, they typically cause rapid, shallow breathing, a sensation of breathlessness, dyspnea, bronchoconstriction, and increased mucus secretion. Think of it as a defense pattern. Try to limit damage and clear things out.
It really is layers upon layers of control and protection. Okay, shifting gears slightly, what about us taking control? Our ability to consciously decide to hold our breath or sing or talk. How does that fit in?
That's the domain of the higher brain centers, particularly the cerebral cortex. Your cortex can essentially send direct commands down to the respiratory muscles, overriding the automatic brainstem rhythm, at least for a while. This voluntary control pathway is quite distinct from the automatic CPG pathway.
Which is why we can choose to hold our breath when diving underwater or control our exhalation precisely to play a flute.
Exactly. Speaking, singing, playing wind instruments, these all require exquisite voluntary motor control over breathing.
But as anyone who's tried to hold their breath knows, that voluntary control has its limits, right?
Absolutely. It's not absolute power. Eventually, the chemical drive from the chemoreceptors, that rising PCO2 and falling pH, and eventually falling O2, becomes overwhelming. The automatic system signals become so strong they will break through your voluntary inhibition, forcing you to take a breath. It's a crucial safety mechanism. You literally can't voluntarily hold your breath until you die from lack of oxygen. The involuntary drives will take over first.
A built-in failsafe. And that distinction between the voluntary cortical control and the automatic brainstem control is really dramatically illustrated by that condition you mentioned, Ondine's curse.
Ondine's curse, or congenital central hypoventilation syndrome, CCHS, is a fascinating and, frankly, terrifying illustration. It's a rare genetic disorder, sometimes acquired through brainstem injury, where the automatic control of breathing is severely impaired or absent, especially during sleep.
So while they're awake.
All awake, they can use their voluntary pathway from the cortex to breathe consciously. They literally have to remember to breathe. But as soon as they fall asleep, and that voluntary input ceases.
They stop breathing.
They stop breathing. They require mechanical ventilation, especially during sleep, for their entire lives. It's a stark demonstration that these two control systems, voluntary cortical and automatic brainstem, are truly separate entities. To forget to breathe. It's chilling.
It really is. It just hammers home how much we rely on that automatic pilot. And beyond these deliberate actions, how does the brain manage breathing during other complex things, like, say, swallowing or even yawning?
Yeah, the brain is constantly orchestrating breathing around a host of other non-ventilatory behaviors. Swallowing is a great example. You need to briefly inhibit breathing at just the right moment to prevent aspiration, food going down the trachea. The brainstem has intricate coordination circuits for this. Yawning, coughing, sneezing, vomiting. They all involve complex, stereotyped patterns of respiratory muscle activity coordinated with other motor systems.
And emotions, too. You mentioned gasping and fear.
Definitely. Affective states, our emotions have a powerful influence. Think about hyperventilating when anxious, sighing with relief, gasping in surprise or fear. These responses are mediated by connections from the limbic system, the brain's emotional centers, down to the respiratory control centers in the brainstem.
So it's this constant juggling act, isn't it? Balancing the absolute need for stable gas exchange with allowing us to talk, eat, react emotionally, exercise. It's an incredible feat of physiological multitasking.
It truly is phenomenal. Think about a musician playing a trumpet.
Yeah.
They might take rapid, deep breaths in and then have very long, slow breaths out. Their PCO2 might fluctuate quite a bit from breath to breath, but over the course of playing, it averages out. Or an infant suckling, feeding is the priority, so PCO2 might rise a bit temporarily. During really heavy exercise, your chemical drive is so strong that trying to talk is reduced to just short gasps between breaths. The priorities shift constantly.
And all these different demands and controls result in this whole library of breathing patterns we can see, from just a normal sigh all the way to very abnormal patterns in disease states.
That's a great way to put it, a library of patterns. The brain's control system isn't just on-off or fast-slow. It can generate sighs, yawns, hyperventilation patterns, the deep, rapid Kussmaul breathing seen in diabetic ketoacidosis, the strange waxing and waning pattern of Cheyne-Stokes respiration, often seen in heart failure or stroke, terminal gasping, or even apnea, the complete cessation of breathing. These patterns tell us a lot about the state of the control system, whether it's adapting normally or struggling due to disease.
Wow. Okay, so let's try and quickly pull that all together. We've uncovered this really remarkable system. You've got the automatic rhythm generator deep in the brainstem, the CPG.
Setting the basic beat.
Right. Then you have these vigilant monitors, the peripheral chemoreceptors in the arteries, and the central ones in the brain itself, constantly checking our blood gases, O2, CO2, pH.
Providing that crucial chemical feedback.
And on top of that, you have all this intricate modulation coming from sensory receptors in the lungs, plus powerful commands from higher brain centers for voluntary actions, emotions, and coordinating with everything else we do.
It allows us to adapt breathing to literally everything: sleeping, sprinting, singing, sensing danger. It's truly a marvel of physiological engineering.
It really is. And you, listening, you are mastering incredibly complex material here. Every connection you make builds a stronger foundation. Remember, you're part of the deep dive family, and you are absolutely capable of conquering this stuff.
Yeah, absolutely. Keep connecting those dots.
So maybe a final thought to leave you with. The next time you take a breath, a deep one, a shallow one, even just that automatic one you weren't thinking about, consider this. What other seemingly simple automatic body functions are governed by such an intricate, hidden network of controls, constantly balancing our survival needs with all our everyday behaviors?